Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Taussig Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. So moving on, a 65-year-old man with a new diagnosis of diffuse metastatic RCC, lung and bone involvement in the setting of a prior renal transplant. And so this is actually one of my patients. So the question is really about how to approach this patient, whether surgery has a role in which systemic therapy. So this is a patient who presented a few months ago with hematuria. He was on warfarin. I can't exactly remember why. Also had weight loss and had some bone pain and shortness of breath. He was performance status, I would say at least one or two. He had a renal transplant 2.5 years ago. For medical renal disease. He was currently on multi-agent immunosuppression, including mycophenolate, tacrolimus, and prednisone. No real relevant social or family history. CT scans, which were just done early this year, that I think we'll see. So concerning for a native kidney, right lower pole RCC, and then the metastasis to multiple organs that you see listed there. Mesenteric nodes as well, pulmonary nodules and pleural nodularity, as well as a right sacral lesion. So unfortunately, walking in the door with sort of diffuse symptomatic distant disease. And then a couple images, and I'll go back to Dr. Siegel to describe what she sees here.
So we have two axial images from a non-contrast CT. And if we look at the image on our left, there's a lobulated mass in the right native kidney. Now, this is a non-contrast study, so on this study alone, it would be very difficult to state what this lesion was. And options would include renal neoplasm, lymphoma, a cyst that bled and had some subacute heme elements. And I think it would be unusual, but even some sort of thrombosed aneurysm from prior renal biopsies. So on a non-contrast only, we have to be a little careful diagnosing a renal cell carcinoma, because we radiologists really like to see the mass pre and post-contrast and look for enhancement. In patients with renal insufficiency, we do have options. If they can't undergo a CT, sometimes we can do an MR pre and post-contrast. And we have an option to do ultrasound with microbubbles pre and post contrast to see if the lesion's enhancing, if we need to. And then on the other image, we see a pleural-based mass in the left chest. And this is something that we could also biopsy. We tend to biopsy pleural-based masses with ultrasound if we can get a window between the ribs. We find it a little easier than CT, but this would be accessible for biopsy should we need that. And the renal mass would also be
accessible, yeah.
For biopsy if needed. I was going to say, if somebody didn't want us to do pre and post contrast CT or pre and post contrast MR or ultrasound with microbubbles, we could just biopsy.
Yeah. And unfortunately, this patient had a lot of potential areas to biopsy. Oops, sorry. So he does undergo a CT-guided biopsy of the left pleural mass. Metastatic RCC, pretty typical, PAX8 and CA9 staining that would indicate clear cell RCC, negative for other things to rule out other malignancies. So the question is really about sort of next step. So Dr. Abel, I'll let you sort of weigh in on the first one. Is this the kind of patient that you want to go in and remove that native kidney as a debulking step?
Yeah, so I think these are always difficult patients. We have a large transplant program, and so we do see quite a reasonable amount of patients like this. I do think that the bulk of disease in this patient is outside of the kidney, and it doesn't seem like there's really symptomatic reasons to remove the kidney. So I think that this is not somebody that we'd expect to have a real benefit from an upfront cytoreductive nephrectomy.
Yeah, I agree with you. Dr. Dricacchi, how about systemic therapy? So you have a transplant patient who's actually in reasonable shape. He's pretty symptomatic. His performance status is down from his symptomatic cancer, of course, but otherwise had been doing well before this. His transplant is stable. His immunosuppression has been stable. He's not going to get surgery, as Dr. Abel just said. So how do you want to treat this patient? What systemic therapy would you choose?
So I have actually a couple of patients like this, and upfront I'm discussing with them what is the spectrum of medications that they're approved for their disease, knowing that transplant patients cannot go into clinical trials. Early on, I discussed about immune checkpoint inhibitors and the knowledge that if we give that, they have high risk of rejecting the transplant. So early on, I discussed with their nephrologist, if the plan long-term is to try an immune checkpoint inhibitor, do we have the ability to restart patient dialysis? And does the patient want to go through dialysis in order to live longer? So immediately after the diagnosis, I usually start with a VEGF inhibitor, but I always have this IO as a backup while I'm preparing the option of dialysis if patient wants to. So I have to say that I have a patient that went from one IO to another. At some point, we tried the mTOR inhibitor. We had to adjust the immunosuppressive therapy, but ultimately started the patient on immunotherapy and did not reject the transplant. So we still don't know who are the patients that are going to reject, but there is not a clear way to identify that early on before we start treatment.
Yeah.
Dr. Dricacchi or Dr. Rini, in a patient like this who is on multiple agents for immunosuppression for their transplant, do you start with backing off some of those agents, or do you keep those on all the agents together?
Go ahead.
So for patients with clear cell, again, I discuss with their nephrologist. Sometimes they decrease the tacrolimus dose. For patients that have urothelial with a post-transplant, we have to modify when we want to give chemotherapy just because of the bone marrow suppression. But for clear cell, maybe some modification, but not necessarily. At least this is our practice in our UCLA transplant team.
Yeah, this was, I think, the first patient I've ever seen, honestly, in this circumstance. So I don't have any experience. I don't know that anybody really knows. We think immunosuppression has something to do with kidney cancer, but I've not really seen data that backing off would be helpful, and so, and we weren't brave enough to try immune therapy. I don't know if there's any published literature on immune therapy in these patients.
I published one after my patient, but it was like small case series.
Yeah,
we just tried to just a couple of patients.
Sure. Yeah.
And of course, we have the guts to do it on a kidney transplant patient. Obviously, on a cardiac transplant, we didn't do it. On a liver transplant, we didn't do it. But the patient was willing to take the risk of dialysis.
Yeah, and I think that's the critical part, because I would assume they would reject. That was my assumption in talking with this transplant doc, that he would definitely reject with immune therapy. And so we chose single agent Cabozantinib in this patient. Pick your favorite TKI. I'm not sure that it matters. So and he just started, I think, a couple weeks ago, so I haven't seen him back, but doing well, say a month in. So just to summarize, this was a gentleman, unfortunately, who presented with advanced RCC in the context of a prior renal transplant. The panels recommended not doing a debulking nephrectomy, and I think that's perfectly reasonable, just based on lack of symptoms from the primary tumor and, more notably, more extensive extra-renal disease. There was some discussion around the potential use of immune therapy, but I think the consensus is start with single-agent TKI and then consider immune therapy if the patient's willing to risk the transplant, if the patient and his transplant doc are sort of willing to do that. So we'll see what happens in the future. Hopefully he has a nice long response to TKI. We don't have to worry about that next decision step for a while. Let me ask.
And I guess radiation could be an option in the bone metastases when they have pain, and that sometimes, again, we know the abscopal effect is not as common, but you could have some control of the disease, control of the symptoms, buy some more time on the systemic therapy. So I don't know if Dr. Shah has treated a patient like this.
We can't get through a tumor board without talking about abscopal effects. So I was just about to ask.
I have one patient in the 11 years that I'm treating patients, only one,
Exactly.
that had widespread disease, head to toe, full of bone mets, lung mets, developed a C2 lesion. It was a critical location, so he got radiation, NET scan, complete response, and it's 2.5 years of therapy.
So Dr. Shah, do you want to comment on maybe just more broadly about integrating radiation? And I ask because in a patient like this, he had some sacral pain, but really not much. So we just started him on systemic therapy. But there are some patients where I struggle a little bit. And I say, well, I can either, pause, radiate, then wait and give him systemic therapy, or just put him on systemic therapy and see how it goes. How do you see that balance?
I mean, I think, when it comes to this, setting outside of the abscopal effect, this is mostly palliative therapy. And so if he's not having a lot of pain, if he's not having an impending risk of a fracture or something like that, I'm always comfortable starting systemic therapy and then reevaluating radiation therapy. High quality radiation in these situations can be started relatively quickly. So, if you were to call me and tell me, he's really having a lot of pain, this is something that, palliative radiation should be able to be started in a day or two in a situation that, it's needed. And my radiation therapy outside of the abscopal effect is not going to impact survival. And so I much rather, use systemic therapy first. In terms of the abscopal effect, it's the radiation oncology unicorn. We all have seen cases, very rare cases, and read papers on it. But I think there's a lot to be figured out about it in terms of which patients develop it. Is it a low dose, a high dose phenomenon? How do we integrate it with the use of IO in all types of cancer? So I think it's something that will continue to be studied, but is exquisitely rare in actual incidence.
Yep, agreed.